trying to move as fast as possible, but please do interrupt me if anyone has a question. When we go into these procedures, it's important to know what we're planning for. Many devices have been designed. Generally, we're seeing a plug, which is the Watchman, and a double seal, which is the amulet. And from now on, I'm going to refer to these devices as such. And basically, we need to understand what we're measuring. One of the complaints that I always get when we're doing these procedures, particularly from reps, is they tell me CT tends to overmeasure. And I really do disagree, and I disagree passionately. We cannot overmeasure anything that has not changed in measurements. There are different physiological conditions that we need to understand. Number one, was the patient given IV fluids before he or she was scanned for the CT? Number two, once we put a patient on the table for this procedure, the patient has been NPO for over 12 hours or more. Your volume status is going to change. Was the patient given fluids before we started the procedure, right after being intubated? All of those things matter. What the left atrial pressure was upon transeptal puncture. And lastly, we need to understand what each procedure is measuring, what the CT is measuring, and what the TE is measuring. And for that, I have made these diagrams for you. Think about the 3 o'clock, your PA is here. This is going to be looking into the left atrium, and this is going to be looking into the lateral wall. This is how the angles that you get on 2 DTEs. I do 2 DTEs for these measurements, but I insist that for every case we do 3D MPR TEs. They correlate very, very well to this CT measurements, and this is where the CT measurements are. We have a growing body of evidence that is extremely robust regarding this CTA, and I would encourage every single lab on the planning for these procedures to have the planning CT and the post-procedural CT evaluation after implantation. The measurements are a little bit different for each device, and it's important to know what you're planning on doing for each patient. So, and this is how some of my cases that I planned. This was done with Remencia, another vendor. And the way that I like to show this is because it allows me to see the entry of the inferior vena cava. And remember that for these procedures, we're coming from the iliacs. So it is the concept of a hanging heart. As we see pathology in the heart and the atria dilate, remember that the relationship of the IVC into the right atrium changes, and that is going to be very important for your transeptal puncture prediction. You can see it here, and how it's going to correlate with the left atrial appendage. The structuralists have mitigated some of this by the new flexible steerable sheets, but a while back ago, that was not so much of the case. And here you can see other features that we need to look into. For example, the interatrial septum. Is there lipomatous hypertrophy? And that's going to be very important to describe, because it's going to tell the interventional how much stenting or how aggressive the person has to be. Is there patent foramen ovale? And remember that a foramen ovale is not a dichotomy, present or absent. Now we have realized it's a spectrum in which you can be partially unroofed, you can be fenestrated, and all of these things are important when we're there, because we want to avoid any damage to an area that we don't have to. And lastly, we need to describe how angulated, whether you're anterior looking into the PA, if you're looking lateral inferior, or if you're looking posterior, because that will also dictate how the septostomy is optimized. So this was this case in particular, and you can see my correlation with my 3 DTE. We do all of our transeptals with 3 DTEs. You can see here inferior, superior, anterior, posterior, and I have labeled it for my interventional colleague, and I put it on fast so they see it. And look at the relationship of this. It doesn't portray here very well, but there was almost an incontinuous septum primum and secundum with almost a membrane or channel-like structure dividing the two. And once you go into this 3D, you can see that this fossa perhaps is partially unroofed. So it's important to keep all of those things in mind. This is also more planning on how we measure and how we correlate to what the interventionalist is going to be seeing. And this is all for this particular case at the time of deployment for those angles. So not important you're going to have access to these slides, but this is a paper by Oliver Baker that's saying when we do this, number one, we decrease the number of devices used. Number two, we decrease the number of repositions. And I can tell you that of all the complications we've seen, and you're going to be seeing complications once you do a certain volume of cases, it always comes by dictated very much by the number of devices, the number of repositions that you do. It also decreases the amount of radiation and improves the first-time closures and the amount of device leaks and device-through leaks, as well as DRT. This is a study by Renard, and I think this was Becky Hahn was involved in this one. And it's actually stated that what I had mentioned before, that once you do 3D, it correlates very well with your CT pre-procedural planning. So this was a case of a patient of mine that he was bleeding on oral anticoagulation. And this is why it is important to get some of these CT planning cases. I was able to tell him that there was no depth. You can see here that there are all of these finger-like projections. So this is a very hostile anatomy. This patient, we needed to do a TE for. The TE completely correlated. You can see on my 3D TE here how it's opening the same way that it was in this CT. And basically, this hostile anatomy would not be feasible for closure.